Thank you, and good morning, everybody. We're really excited to be able to talk about this very specialized topic, but that has worldwide implications and implications for nursing. So we have not shared this with anyone outside of the wound community yet, so we're excited to be here. I am the interim past president of PAWSIC, the Post-Acute Wound and Skin Integrity Council. I'm from York, Pennsylvania. I'm a wound ostomy continence nurse, but I spent 32 years in Baltimore and actually did some of my early nursing training right across the way at Bayview Medical Center. So if you have any Baltimore questions, you can ask me while I'm here. This initiative started back in October 1st, 2023, when the Centers for Medicare and Medicaid, CMS in the US, implemented a new guidance that was very specific to skilled nursing facilities, long-term care, but has implications across the continuum of care. And this one sentence has just absorbed my whole life for the last year. They said skin changes at the end of life or scale, also referred to as Kennedy terminal ulcers and skin failure, are not primarily caused by pressure and are not coded in Section M on the MDS in long-term care. And that's a lot of jargon, I know, but what it means is that there's been recognition by our authority and payer that end-of-life wounds of all kinds aren't the same as pressure ulcers and shouldn't be documented as such. And this is a really important distinction that some of us in nursing have been working on for the last 35 years. So it meant, though, that those end-of-life wounds, scale, Kennedy terminal ulcer, skin failure, don't have a diagnostic code. And in the US system, that means there's no way to bill for them and get reimbursed for them. This differs across the world, but in the US, ICD codes drive reimbursement. And so it's a big problem. In other countries, the ICD-10 or 11 codes, whatever you might be using, aren't always associated with reimbursement. So it's not as much of an issue, but this is a big clinical assessment issue and ultimately a quality of care issue. Because if people have end-of-life wounds that are not healable, they should get palliative wound care, not aggressive wound care. So that's where it becomes an issue for all of nursing and all of healthcare for that matter. So our association, the Post-Acute Wound and Skin Integrity Council, which is a relatively new group, had our first meeting on November 2nd of last year. And one of our board members brought up this new coding problem. And we decided to explore applying for an ICD-10 code for end-of-life skin and wound changes. Now, those ICD-10 codes are specific to the United States, but the rest of the world has similar coding systems, and it varies from country to country. Most of Europe is using ICD-11 now. So if other countries want to take this information and use it in their country, they'll have to go to their ICD authority and ask, how do we use these new codes? So a group of us mobilized to pursue this issue. And the deadline, it turned out, for submitting a proposal to the ICD-10-cm committee was just a few weeks away. So we submitted our first proposal on November 28th, and it was for skin and wound changes, at the end of life. We chose to use that wording because it would be all inclusive, but later on we had to change it to skin failure because the ICD-10-cm committee didn't consider end of life an outcome. They considered it an outcome, and we needed to have a diagnosis. And so we had to choose the terminology skin failure. So it's been quite a journey, and it's going to go on for a while. And we didn't realize that when we started. We submitted our first proposal, got a request for more information, and in February, the ICD-10 committee actually requested that we start working with the American Academy of Dermatology Association because they had lots of experience with obtaining codes in dermatology. And it's been a great collaboration. We submitted a second proposal using the terminology skin failure in June of this year. In just a month ago, on September 10th, I presented to the ICD-10 committee the codes that I'll share with you. And we are now in a public comment period. If the codes are accepted, and our fingers are crossed that they will be, they will go into effect October 1st of 2025. So it's a long journey between now and then. We'll have to do teaching with various organizations in the United States. So what we've done in the meantime is several webinars on end-of-life skin and wound changes. There's a lot of confusion about this in the nursing and wound care and healthcare community. And then we did a virtual roundtable where we invited international participants to make comments and look at this proposed code structure that we've put forth. So I'm going to share with you just a quick snippet of what this code structure is. And if you'd like more information, I'm happy to email you my presentation, our code. I have some hard copies of our coding proposal if you'd like to take it, or I can email it to you. Just catch me during the course of the meeting. So we chose to use the conceptual framework that was developed by Diane L and Greg Brown and published in 2006 for acute, chronic, and end-stage skin failure, because we felt that it was the most clinically relevant and would be the easiest for our clinical partners to embrace. So acute skin failure is an event in which skin and underlying tissue die to hypoperfusion concurrent with a critical illness. This is what you see in ICUs. These patients have multi-organ system failure or acute renal failure, acute respiratory failure. And the underlying etiology here is hypoperfusion versus pressure. So that's what distinguishes between pressure injury and skin failure. So, if you look at that wound, you might think, oh, well, that is a deep tissue pressure injury. But you have to do a thorough patient assessment and look at the underlying causes. And of course, this is a huge area in the United States for litigation. So that's another reason why we are interested in getting this clarified, maybe not so much in the rest of the world. So we've proposed 3 codes under each of a new subcategory. I'm using ICD-10 language here. So the new subcategory is acute skin changes due to skin failure. And then there are 3 codes, one for skin intact, one for partial thickness, and one for full thickness. So now we move to the next group, chronic skin failure, an event in which skin and underlying tissue died to hypoperfusion concurrent with chronic illness. Some examples would be chronic respiratory failure, chronic renal failure, congestive heart failure. And here you see a large black, brown, tan, red sacral coccyx wound, full thickness. So again, it's parallel here. There's a new subcategory and then 3 new codes for skin intact, partial thickness, and full thickness. We tried to keep it simple. Any of you who are familiar with pressure injury coding, there are hundreds of codes based on the level of damage. It's pretty complicated, and we felt that was unnecessarily complicated, and the ICD-10 committee asked us to try to keep it simple. So the last category, which is actually the one that's been most researched and has the most publications, relate to end-stage skin failure, things like Kennedy terminal ulcer, Trombley-Brennan terminal tissue injury, skin changes at life's end. So these are all events that are concurrent with end of life. Failure to thrive might be a concurrent condition, a palliative diagnosis, a hospice diagnosis. And here you see a full thickness wounds on the bilateral buttocks. And again, the subcategory proposed code is for end-stage skin changes due to skin failure. And the new codes are skin intact, partial thickness, and full thickness. So the goal of our collaboration between the American Academy of Dermatology Association and PAWSIC was to develop a coding proposal that was applicable across the continuum of care, inclusive of publications and research in this area over the last 35 years, to be consistent with the ICD-10-cm and CMS nomenclature, which is a challenge because they're not always consistent, but we did the best we could, and to be simple and practical for clinical use. We realized that these code proposals had international implications because this is not a phenomenon that is restricted to long-term care in the United States. It's going to impact across the continuum of care in acute care facilities, rehab, long-term care, assisted living. It's home care, it's everywhere. And so we also realized that there are many other countries that have been looking at these situations, and we wanted to be inclusive for everybody. So our plan in collaboration with other organizations will be to develop recommendations for clinical practice and also guidelines for coders. And that's really important, especially here in the US. We have lots of coders that are going to have to learn how to distinguish between skin failure and pressure injury. So we went out and asked for national and international organizations, mostly wound care, but also some general ones, to endorse this proposal before we presented it to the ICD-10 committee. And we have 12 endorsing organizations, some of whom are general, like the American Healthcare Association, and some of whom are very specific to wound, and then several international groups, the International Interprofessional Wound Care Group out of Abu Dhabi, and the International Skin Care Advisory Panel, and the World Union of Wound Healing Societies. So we are currently working on a clinical assessment tool to help clinicians distinguish between pressure injury and hypoperfusion, because that was when we did our roundtable and we presented at the ICD-10 committee, we got a lot of questions about how do you differentiate between these two. And of course, it's not so easy, but we're working on this flow diagram, and we're going to work on one then for providers, and then we're also going to work on guidelines for coders. So just to conclude, here are some of the implications for nursing practice worldwide. So this will provide a common language for assessing, diagnosing, and documenting skin failure worldwide. There are several groups that have done some incredible work on this topic, including Sharon Latimer and her group at Griffith University in Australia. They've developed an end-of-life assessment tool, end-of-life wound assessment tool, and other groups that have been exploring this issue of skin failure. Having codes will help us ensure accurate clinical assessments and appropriate targeted interventions, thereby improving quality of care for skin failure patients globally. So it's important that we recognize that these patients should be treated differently, that their wounds may be unavoidable, and that many of these wounds are unhealable due to the condition of the patient. And so care may have to flip from a aggressive care pathway to a palliative care pathway. Recognizing skin failure will provide a foundation that can be used across populations to analyze prevalence, incidence, trends, and outcomes. One of the problems we have is that so many skin failure wounds are coded as pressure injury that we can't really tease out the data. Both data sets are contaminated. And if we have better information, we'll be able to see how many of these patients really, died of a pressure ulcer, and how many of them had skin failure due to hypoperfusion due to other comorbidities. We hope to be able to start collecting data internationally and do more research on what are those concurrent conditions. How many do you need? Is just having acute respiratory failure enough? Or do you need to have anemia and acute respiratory failure? And which ones are the most important of those concurrent conditions? Or is it 2 or 3 multi-organ systems that you need to see failing before you see skin failure? These are all important questions that we don't know the answers to yet, but having codes will help us get large data sets that we don't have now, and will help us to do better nursing research. And then it will help us inform policymaking for this group of patients. So thank you